Hello learners, welcome to lecture 49 from module 7. In the last module, we closed with a discussion on monitoring and evaluation frameworks for community-based RCH programs. That set the stage for this new module where we will go deeper into research and evaluation itself. Today's lecture introduces you to research methods in reproductive and child health. We will discuss why research is critical, the types of methods commonly used, and how they help generate evidence for policy and practice. By the end, you will appreciate how rigorous research informs better programs and ultimately better outcomes for women, children, and families. Research in RCH is the backbone of evidence based decision making. It helps us understand why certain health behaviors persist, how systems function, and what interventions make a difference. Without research, programs would be based on assumptions rather than facts. Research ensures resources are used effectively and health priorities such as reducing maternal mortality, improving immunization coverage, and addressing adolescent health are guided by real data rather than speculations. The objectives of research in RCH are multifaceted. First, it seeks to identify determinants of health, such as socioeconomic status, gender roles, or environmental exposures. Second, it measures the burden of disease, including maternal deaths, infant mortality, and child malnutrition. Third, it evaluates the effectiveness of interventions like conditional cash transfers or immunization campaigns. Finally, research informs policies and practices, ensuring that national and global strategies are rooted in evidence. To achieve these goals, researchers use both numbers and stories. Surveys, routine data, and interviews with women, families, and providers. Data sources like the National Family Health Survey and the Sample Registration System help track trends over time and compare regions. Studies show always check for equity. Who benefits, who is left out, and why. Clear ethics, consent, privacy, and respectful engagement are essential at every step. Findings must be shared in simple language with communities and decision makers, not only in journals, so actions follow quickly. When research is continuous and practical, it guides smarter programs and saves mothers and children's lives. RCH research can be classified into descriptive, analytical, experimental, and operational. Descriptive research documents its status quo, such as child mortality rates in a district. Analytical research looks at associations, like how maternal education affects child nutrition. Experimental research tests interventions, such as clinical trials of vaccines, while operational research focuses on how programs are implemented in the real world, asking practical questions like how to increase uptake of family planning services. Descriptive studies use routine records and surveys to map where problems are worst and which groups are most affected. Analytical studies control for confounders to see if a relationship is likely to be real, not due to other factors. Experimental studies, especially randomized trials, show cause and effect, but need strong ethics, informed consent, and safety monitoring. Operational research is quick, low cost, and done with program teams to solve day-to-day delivery issues. Many projects blend methods, quantitative data for scale and qualitative interviews for why, to give a full picture. The right decision depends on the question, timelines, and resources, but all types should report results clearly so managers can act. Quantitative methods are widely used in RCH. They include surveys and structured questionnaires to collect large-scale data. Epidemiological studies like cohort or case control designs explore risk factors and outcomes. Statistical analysis then allows researchers to identify patterns, measure associations, and test hypotheses. The strength of quantitative methods lies in the ability to generate generalizable results and measure population level trends. Good quantitative work starts with a clear research question, a well defined population, and an appropriate sampling method so results represent the community. Researchers choose valid indicators. For example, maternal mortality ratio, infant mortality ratio, immunization coverage, and use tested tools to reduce errors. Data quality checks, pilot testing, training of field teams, and double entry protect reliability. Analysis should adjust for confounders and report confidence intervals so readers understand the precision of estimates. Results must be broken down by sex, wealth, caste, tribe, and location to reveal inequities, not just averages. Finally, findings are best shared with simple tables, charts, and clear policy messages that program managers can act on quickly. Qualitative methods complement quantitative ones by providing depth and context. Focused group discussions explore collective perceptions while in-depth interviews capture individual experiences. Participation observation allows researchers to immerse themselves in communities to understand cultural practices and beliefs. In RCH, qualitative methods are invaluable for uncovering barriers to care, stigma, and cultural norms that numbers alone cannot reveal. Mixed method research. It combines the strengths of both quantitative and qualitative approaches. For example, a survey may measure immunization coverage while focus group explore why some parents resist vaccines. Together, these provide both breadth and depth, giving a more holistic understanding. In RCH, mixed methods are often used in program evaluations where both numbers and narratives are important. Epidemiology provides the foundation of many research studies. Cross-sectional studies measure prevalence at a single point in time. Case control studies compare those with and without an outcome to identify risk factors. Cohort studies follow groups over time to establish causality. Intervention trials, including randomized control trials, test the efficacy of new treatments, vaccines, or service delivery models. Each design has its strengths and limitations, depending on the research question. Cross-sectional studies are fast and low cost, but they cannot tell us which came first, the exposure or the outcome. Case control studies work well for rare diseases and are efficient, but they rely on past information which can be biased. Cohort studies show the time order clearly and help estimate risk, yet they need more time, money, and strong follow-up systems. Randomized control trials give the strongest evidence of cause and effect, but they must follow strict ethics and may not reflect real-world conditions. For each design, clear definitions of exposure and outcome, good sampling, and careful measurement are essential. Researchers should plan sample size to ensure enough power to detect meaningful differences. They must also consider confounders and use appropriate analysis to avoid misleading results. Finally, choosing the right design depends on feasibility, timelines, ethics, and how directly the findings will guide RCH programs and policies. Operational research is particularly relevant in RCH because it examines how programs function in practice. It asks pragmatic questions. Why do some women avoid institutional deliveries despite free schemes? What prevents ASHA from achieving full immunization coverage? By identifying the barriers and testing solutions, operational research directly informs program managers and improves efficiency. It uses simple tools like process mapping, bottleneck analysis, and short plan, do, study, act cycles to find what works in real settings. Small pilots such as transport vouchers, SMS reminders, or redesigned clinic flow are tested quickly and scaled if they help. Results are tracked with easy measures and broken down by gender, poverty, and location to make sure equity improves. Frontline workers, community leaders, and mothers should co design the fixes so changes fit local culture and daily life. Ethics are basic but vital. Informed consent, privacy, and no harm. Most importantly, findings must be shared fast in district review meetings so managers can act, not just written up in reports. Community based research emphasizes participation, where communities are not just subjects but active partners. They help design research questions, collect data, and interpret findings. This approach ensures cultural appropriateness and increases the likelihood of acceptance and sustainability. In RCH, involving communities is particularly important because many interventions address deeply rooted beliefs and practices. Data sources for RCH research include national level surveys like the NFHS in India or DHS globally, which provide representative data on key indicators. Health information systems give routine service statistics, while facility records offer insights into service delivery. Community based studies fill gaps by exploring contexts that large surveys might miss. Each source contributes unique value. Ethical issues are central in RCH research because subjects often include women, children, and adolescents considered vulnerable. Informed consent ensures participation is voluntary and informed. Confidentiality protects sensitive health information. Safeguards must be in place to protect participants from harm, stigma, and exploitation. Ethics committees play a key role in reviewing proposals to uphold these standards. Sampling is critical to ensure validity. Random sampling ensures each individual has an equal chance of selection. Stratified sampling divides populations into subgroups like rural versus urban. Cluster sampling is often used in large scale surveys, while whole villages or blocks are selected. In qualitative research, purposive sampling ensures inclusion of diverse voices, such as women of different age groups or socioeconomic backgrounds. Add these basics. Define a clear sampling frame and calculate an adequate sample size allowing for non-response. In cluster designs, account for design effect so your sample is not too small. Use weights in analysis when some groups were oversampled or have different probabilities of selection. Always document inclusion-exclusion criteria and keep selection steps transparent to reduce bias. For qualitative work, combine purposive and maximum variation or snowball sampling to reach hidden groups and keep sampling unit thematic saturation till it is reached. Finally, obtain informed consent and track refusals so you can assess whether a non-responsive might skew your results. Data collection tools vary depending on design. Questionnaires and interview guides structure the process for surveys and interviews. Observation checklists ensure systemic recording of behaviors or facility conditions. Increasingly, digital apps are used for real-time data entry, reducing errors and speeding up analysis. Well-designed tools are the backbone of reliable research. Validity ensures that the study truly measures what it claims to measure. For example, a questionnaire on maternal health actually reflects maternal practices and not genital attitudes. Reliability means that results are consistent when repeated under similar conditions. Both validity and reliability are non-negotiable for credible research in RCH. Quantitative analysis begins with descriptive statistics, percentages, means, and graphs that summarize the data. Inferential statistics then test hypotheses. For example, whether difference between groups is significant or insignificant. Regression analysis explores associations while controlling for confounders. Together, these tools turn raw data into actionable insights. Start with clean data and a clear codebook. Then show descriptive results broken down by gender, wealth, caste, tribe, and rural urban so inequities are visible. Choose the right tests. For example, chi-square for proportions, t-test or ANOVA for means, and non-parametric test when assumptions are not met. And always report confidence intervals and p-values. In regression, check assumptions, include important confounders, and interpret coefficients in plain language. What a one-unit change really means for mothers or children. If you use complex sampling, apply weights and account for clustering to avoid biased results. Use simple visuals like bar charts, line plots, maps to communicate findings to managers quickly. End with 2 or 3 clear action points so the numbers translate into program decisions on coverage, quality, and equity. Qualitative data analysis involves identifying patterns, themes, and meanings in narrative data. Thematic analysis groups responses under themes, while content analysis quantifies frequencies of specific ideas. Grounded theory builds new concepts directly from data. These methods allow researchers to interpret the why behind the behaviors in RCH. Start with a careful transcription and read the data several times to become familiar with it. Create simple codes, group them into themes, and keep an audit trail so others can see how you reached your conclusions. Use 2 coders when possible and discuss the differences to improve reliability. And continue collecting data until you reach saturation. Add short anonymized codes to give voice to women, families, and health workers, always with consent and privacy protected. Practice reflexivity by noting your own position and possible bias, and use triangulation to check findings from multiple angles. Finally, share results back with communities and program teams to confirm accuracy and turn insights into practical changes. Triangulation strengthens research by combining multiple methods or data sources. For example, survey data on antenatal care may be cross-checked with facility records and focused group findings. When results converge, confidence in finding increases. Triangulation is particularly valuable in RCH where complex behaviors require multiple lenses for analysis. Monitoring tracks progress continuously while research explores questions in greater depth. For example, monitoring may show that immunization rates are falling while research investigates why families are reluctant to vaccinate. Both complement each other. Monitoring identifies problems and research provides explanations and solutions. Research plays a vital role in shaping policy. Evidence from trials or operational research provides justification for scaling interventions. Findings influence national strategies such as India's RCH program or global frameworks of SDGs. Research also acts as an advocacy tool, demonstrating where rights are unmet and demanding accountability. Globally, RCH research has driven major initiatives. UNICEF's GOBI-FFF strategy, growth monitoring, oral rehydration, breastfeeding, immunization, plus food, female literacy and family planning was research driven. Evaluations of integrated management of childhood illnesses have informed its adoption worldwide. Vaccine trials have transformed child survival. These examples show that research is the foundation of progress. In India, NFHS surveys provide a gold standard for RCH data. Evaluations of Janani Suraksha Yojana have shown the impact of conditional cash transfers. Asha's programs assessments reveal the role of community workers in improving health outcomes. These examples demonstrate how research not only measures impact but also guides reforms in national programs. NFHS helps track trends over time like fertility, nutrition, and immunization. So, policymakers can see what is improving and where gaps remain. JSY studies have informed changes such as smoother payment systems and better linkages with free maternity care schemes. ASHA evaluations highlight what frontline workers need: timely incentives, supportive supervision, and regular training to maintain high coverage. Together, these findings shape guidelines, budgets, and targets at national and state levels. Importantly, results are broken down by state, district, wealth, caste, tribe, and rural urban to keep equity in focus. When evidence is shared clearly with program managers and committees, it turns into practical actions that improve services for both mother and children. RCH research faces challenges. Funding and resources are often limited, especially for community-based studies. Ethical complexities arise when working with women, adolescent, or marginalized groups. Even when findings are robust, translating them into policy action is not always straightforward, requiring political will and advocacy. To cope with tight budgets, projects should plan lean designs, share data platforms, and partner with government programs to lower costs. Strong ethics systems, clear consent, privacy protections, and referral support for sensitive issues and are non-negotiable. Researchers need to package results in simple briefs, dashboards, and cost benefit notes so decision makers can act quickly. Building alliances with community leaders, civil society, and the media helps turn evidence into public demand for change. Finally, budgeting for knowledge transition from a start, policy dialogues, workshops, and follow up closes the gap between research and real improvements in RCH services. Solutions include investing in the capacity of young researchers through training and mentorship. Ethical training and oversight ensure participants' rights are safeguarded. Building linkages between researchers and policymakers ensures that evidence does not sit in reports but is translated into real world action. These strategies make research more impactful. International agencies play a key role in standardizing and supporting RCH research. WHO provides guidelines and protocols for maternal mortality audits and health surveys. UNICEF funds and conducts child health research. Global collaborations such as vaccine trials or multi-country evaluations ensure that research addresses global priorities while supporting local contexts. Future research in RCH will increasingly use digital tools, allowing faster, more reliable data collection. Big data and artificial intelligence will be applied to predict risks and design interventions. Community-led research models will place power in the hands of those most affected, ensuring relevance and equity. These innovations will redefine how RCH research is conducted. To summarize, research underpins all evidence-based RCH programs. Quantitative, qualitative, and mixed methods each have a role in answering different questions. Ethics and participation are central to ensure dignity, cultural sensitivity, and accuracy. Strong research creates the foundation for sustainable maternal and child health improvements. In conclusion, research is not a luxury but a necessity in reproductive and child health. It guides programmers, ensures accountability, and provides the evidence needed to achieve long-term impact. Without research, interventions may be misguided or ineffective. With research, we can move with direction, clarity, and confidence towards healthier futures for women and children. As we close, I urge you to reflect on the idea that research gives voice to data and data provides direction for change. Each study, no matter how small, contributes to a larger mosaic of knowledge that shapes our collective ability to reduce maternal and child mortality. As future researchers, your role will be to ensure that knowledge translates into justice, equity, and health for all. This lecture has provided an overview of research methods in RCH, laying the groundwork for deeper exploration. In our next lecture, we will examine study designs in greater detail. How to choose the right design, their strengths, weaknesses, and applications in RCH contexts. This will build your ability to critically assess and conduct research. With that, let us move forward to lecture number 50 on the next turn. Thank you so much for today.